technology can scale our impact and without doing away with our humanity, which I think is what a lot of people are concerned about. Like, is technology and is AI going to rob us of our humanity or dilute it somehow? But I've seen so many barriers in access to care. And so if we're able to use it to get us in contact with people we weren't going to be able to contact otherwise, then I think that just amplifies our humanity.
Hello, everyone, and welcome to our next episode of this podcast. Today, I'm so excited because we have Rosa Hart, who's got a fantastic background from an ICU nurse to a nurse innovator to a community person who's trying to make such a huge difference in the community. Rosa, it's truly my pleasure to be here. I would love to hear your story. And why don't we begin with understanding how you got into what you're doing and what was that moment when you saw the need for somebody to come in and really bridge this gap in communication that happens for especially the stroke patients. Would love to hear your inspiring story.
Well, thank you, Arvind. I really appreciate you including me in your podcast today. I know that's always an honor because people can be very precious about their podcasts and who they let on. So thank you. And I think my journey into tech innovation really came from a podcast that I was doing related to my work in stroke follow-up. And so I have repeated myself a lot as a nurse educating patients, and I've heard a lot of the same frequently asked questions over and over again. And I would have some really high quality conversations with patients over the years, but I still felt kind of limited to whoever I got on the phone, right? So I was able to make a podcast really in conjunction with my day job that allowed me to record those answers to the frequently asked questions and interview experts and other stroke survivors and share those insights essentially with the rest of the world so anybody can hear it wherever there's internet. And that really sparked something in me because it showed me the way that technology can scale our impact and without doing away with our humanity, which I think is what a lot of people are concerned about. Like, is technology and is AI going to rob us of our humanity or dilute it somehow? But I've seen so many barriers in access to care. And so if we're able to use it to get us in contact with people we weren't going to be able to contact otherwise, then I think that just amplifies our humanity.
It is so true and sounds super inspiring. So tell me about your journey. I know you were a neuro ICU nurse initially, and then you moved to the helping the post-stroke patients sort of navigate the journey and in recovery long term. Talk to me about what is the biggest challenge that you're trying to solve? What's broken fundamentally in the patient care? Like, what happens from a patient's perspective when you suffer from a stroke and then you're discharged? What's really the challenge?
Well, there are plenty, right? But in addition to the education barrier, which is profound, actually, how about I just start with the education barrier? Because especially in stroke education, we have the standard of you have to provide them with a written instructions and education before they leave. Sometimes that doesn't make it past the door and it ends up in the trash can. So just seeing how written things don't always make it to people and people don't always read these days anyway. Some people also, like I'm in Kentucky, and in Kentucky, we have some literacy limitations as well. So all of those kind of combine to creating a barrier to that written education being enough. And a lot of times people want to hand somebody something to read instead of actually talking it through. And I don't know about you. I'm a talker and I learn through interaction. And so I relate to my patients who learn that way as well, through that question and answer and teach back. And so I have found it to be very helpful to just have an audio version, for example, to overcome that barrier. But then, of course, there's also barriers to paying for things so they can have access, whether it's they can't get a primary care provider because there isn't one in their area who will take them if they are uninsured or they have the wrong insurance for whatever providers are nearby to them. Or they just like live out in the what we call the boonies, which is just
What's that? What's the boomies?
what's the
Like the
boonies?
woods?
Well, I don't know. Can I give away your geolocation right now? You're in the
Yes,
Himalayas right now. So we might call that the boonies. It's
understood.
essentially away from civilization. And so if you're too far away and you don't have transportation to get to where you can get more help, whether it's those follow-up primary care appointments or specialist appointments, which of course are more rare and oftentimes have waiting lists to get in to see a specialist as well, or rehabilitation if you need specialized therapy like for neuro rehab.
Hmm.
Insurance and how much, like, even if you have good insurance that will cover it, then meaning the deductibles, for example, lots of financial barriers. And even aside from that, the cost of driving, or do you need to stay in a hotel overnight in order to get the therapy that you need because it's not available near you? Like, there are a lot of barriers related to that too.
Got it. Well, thank you for highlighting some of those challenges. So it looks like in the way that the information is communicated, that's a big barrier because I know very well as well the H&P and the discharge papers that, for post-acute can be like 100-page document. I mean, and there's multiple sets of documents. Of course, there's one that goes to, let's say, the next provider. Let's say they're ordered a home health service, then they get a lot of that information, but also like information that's given to the patients. And especially, I mean, I'm trying to imagine like these are post-stroke patients. And at times it may be very difficult to comprehend and it could feel really overwhelming. And reading through all of that stuff, it might feel like a very big task. And of course, I mean, I am myself a very audio and visual learner. So what I would do is if I'm getting, let's say, a bunch of documents that I need to understand and read, I would put it into Notebook LM, like, as a technology thing. It's a really cool tool from Google. And I upload some of those documents and then it creates sort of an audio summary for me, or it creates a mind map, it creates a presentation. So those are kinds of things that in technology, at least, many of us are able to do, but we're talking about elderly patients who grew up with not so much technology. So it's not easy for them to, even though now the technology is there and with this big AI push and the wave, and of course we're witnessing, all of these technological breakthroughs, but they're not going all the way down to patients who actually need it. And especially if they're in a setting, like you described, in a rural setting where they don't have the access. Or secondly, you mentioned that there could be other barriers as well, transportation or, socioeconomic barriers and financial barriers. Understood. So you notice this as a challenge as you were communicating with those post-stroke patients and trying to explain to them everything that maybe the hospital may have provided to them to communicate with them. And I've also, I got an opportunity to listen to some of your other podcasts, and wow, what a great job you do and how amazingly you empathize with them. And you raise some of those issues that are often not talked about in, that type of a setting. So tell me a little bit more about like how, because I know you've written a book on this as well. Tell me a little bit more about like how overall you were able to provide this access to some very high quality information for these post-stroke patients. Like, what was your process like in coming up with this information? And, because a lot of times we sort of rely on the experts and the doctors and researchers. And, it may be a challenge to come up with such high quality data. How did you go about doing that?
So the book that I have out right now is called Speak Up, Start Now. Thank you for
Mm-hmm.
bringing it up. And it is about overcoming imposter syndrome because, like you said, I'm surrounded at work by a lot of specialists. And honestly, like, I do interview them in a lot of episodes. I also consult with the University of Miami's Aging Like a Pro podcast, and I interview their brain health researchers. But I found that nurses serve as very good translators for physicians and researchers because, on the one hand, we can understand the medical terminology that they're using, and then we have already had to develop the skill set of translating that to the, I don't know, what would you say, lay people who don't have medical training. A lot of times the doctor will come in and educate the patient and then leave, and then the patient will turn to the nurse and say, okay, what did they say? What does that even mean? Right? So the book was really about, what right do I have to go out and do this education, for example. But if I realize, like, if I can educate people on an individual level, whether it's on the phone or at the bedside, if I record it and put it out there, it doesn't make that information any less valid. It's just another mode of communication. And so there are a lot of instances where, I am the expert in the room, essentially, if I'm speaking to people who are not neuro experts and I'm the one in the room, then just because I don't have a certain title or because I'm quote unquote just a nurse, that doesn't invalidate the knowledge that, I've learned. I am a stroke certified registered nurse, and I think that means something. But at the same time, there are other things that we just don't have to assume we need this external validation for. I think I saw that change, like, in myself. After I got the stroke certification, I was more confident in asserting what I knew. But then I realized whether or not I took the test, I still knew that information. And I was like, well, what else do I know that I haven't gotten a certification in, but I know it, right? And so it just kind of helped flip that switch in my head.
Now that's beautiful. So you don't need that permission from the experts. It's really allowing yourself to, communicate. And this is for the patients, for better outcomes, for empathy, for understanding.
Sometimes I might disagree with other experts. Like, there are some people who think that when we're teaching what signs of stroke we should be educating on, we should only use an acronym in English called FAST, F-A-S-T, which is for face, arm, speech, and time, or terrible headache. But I have spoken to so many patients who did have a change in their balance, and that was like one of their main stroke symptoms. Or they had a sudden onset of visual changes, and actually 60% of people who experience a stroke do have visual changes. And so I am very intent on, anytime I get a chance to educate about what signs of stroke to watch for and when to call 911, that I am including the B and E in front of FAST, because I always have those actual real people in mind, and they're not statistics to me, they're real people. And so I think when we draw on our own lived experience as expertise, that there is power in that, and it may not be validated by the highest authority in the land, but it's also not invalid.
Absolutely. No, that makes sense. So tell me a little bit about the role that technology can play now in making it even more accessible. I love the way that you have this podcast where the post-stroke patients can join, and it's just pressing a button and you don't have to do much, and you could actually hear experiences from other patients as well. Tell me a little bit more about how that process works and what feedback you've received from some of the patients who've joined the podcast and been able to really see that difference.
Well, one of my favorites from this spring was actually, I was speaking with a patient and she was really anxious, and she had just gotten out of the hospital within the last week, and she was freaking out at home and afraid to sleep because she was afraid she would wake up and either she wouldn't wake up, or she would wake up and half of her body wouldn't be working again. And she was experiencing like almost panic attacks at home. And her husband wanted to comfort her, but all he could say is, just relax. It's not really happening. And she felt like she was a crazy person, and she felt like he was losing patience with her and didn't know how to help her. And so I was able to share an episode with them on coping strategies for anxiety and depression after stroke. And that was like on a Friday. And I told her, call me back if you have any questions or if you want to talk about it some more on Monday. And she called me back on Monday and she said, I feel like an entirely different person. When I
Oh,
start feeling anxious, my husband knows what to say to me now. And he talks me through that exercise and I'm able to calm down. And I don't feel like he's upset at me for being afraid. And so it helped their relationship as well as just her as an individual. So moments like that, like I hope it reaches everybody in the world who needs it, but it changed that one person's whole world.
it did. Wow, that's beautiful. And so it's not really about just the patient education, but it's also about caregiver education, the person who's going to be taking care of them. And a lot of times you're right, like they have the best intentions, but
Yeah.
if you don't know what are the best ways to impact that, I think that could be a challenge. Then the audience for you is a lot of the patients and as well as the caregivers. And I know that you have another podcast that is more preventative, where you could even 10 years before something like that might happen, you're doing the right things and you're trying to learn about a lot of techniques that are possible. So one way is the podcast. And now we see all of this generative AI and new technologies and being able to create personalized videos on the fly and personalized audio, as I talked about. What role do you see technology playing over the next few years? What are you hearing from, the experts that you talk to and the guests that you invite on the podcast? Share with me a little bit of your perspective on how technology is going to change a lot of this in the coming years.
Well, I think a lot of people had defaulted to asking quote unquote Dr. Google about their symptoms and things like that. And we would talk about the frustrations with that if you're self-diagnosing based on WebMD or things like that. And now people are asking LLMs for their answers to their questions. And so actually, LLMs are drawing a lot of their answers from platforms like Reddit and YouTube and things that get a lot of interaction like that instead of maybe more validated websites, for example. You can give it parameters, but most people are not going to do that. So just knowing that, it's very important to me that when I share information that I want people to know at large, that I include it on places like YouTube, because those transcripts are then fed into the LLMs and can be factored into these answers that they're given. Now, that doesn't mean it's going to keep it from hallucinating, but it does mean that we're putting that good information out there. And I think a lot of experts have, up until now, wanted people to go to their super legit websites, and that's not what people are doing. So I think we got to meet people where they are and see where the trends are and just go where the people are.
I love it. And you talked about the teach back as well, like actually. So I want to share with you an example of how, we're seeing some of the ways that technology could help, and maybe a good segue to me describing where we're trying to make an impact. So for us, it's definitely all about best outcomes for the patients, but then also understanding the tough job that the clinicians have to do that are caring for those patients, not just the caregivers, the aides, or the family. Of course, that's a huge area where there can be impact, but the clinicians as well. And the problem is right now, when post-acute, when the patient's discharged, they have a home health service and the clinician would arrive, and there's this assessment that needs to be performed for the admissions. And that's the OASIS assessment. That's the outcome assessment information set. And that covers all of the information about the patient, from how much they can ambulate and, what is even their socioeconomic condition, and do they have risk for fall, or, any other like additional devices that they may be using as aid, and how much caregiver support they have available, how they're able to perform the activities of daily living, and all of that stuff. So when they're discharged and the initial assessment is done, that's done. And then comes the care plan that's created with these goals and interventions. And what's happening is that those goals and interventions are there, but that clinicians can get so busy that they would, at times only have time to perform whatever those important aspects are, like, that are medically necessary. But then when it comes to educating the patient, like, let's say, educating them on the fall risk, then they would explain something, but then the patients would forget. So there needs to be a way to leverage the technology that they have access to that information, and then understanding in between the visits, the clinician visits, by maybe even making a phone call to understand, how are you feeling now? Is your situation getting better or not? And then can you describe what you learned in terms of, when you're taking a diuretic, then what are some of the things that you need to keep in mind? Or if it's a CHF patient, then, how to monitor your salt intake and, things like that. So it's not really just, okay, the clinician has explained it to them and then she's checking during the next visit, but even in between visits, sort of doing some sort of remote patient monitoring. So, that is an area that we're trying to innovate. But along with that, what we're also doing is keeping in mind all three sort of, stakeholders in this. As an example, of course, number one priority, the patient outcomes. Saying, how do we get the best outcomes for them? But then looking at the clinicians and seeing that there's so much burden for documentation. So then how do you spend that meaningful time with the patient to give them the education? So what we've been able to do is, through the ambient scribe, record all of that conversation if that's what they choose to do, or the clinician can give a clinical summary and answer certain questions, and the entire documentation gets automatically generated for them. And then they could just review that documentation instead of justifying the homebound status, justifying the medical necessity. And the best part is that with these two stakeholders, there's also the providers. And right now, there are so many pressures on the providers because of the cuts in the Medicare and Medicaid, the funding cuts, and then also the stricter measures, which, I understand that there needs to be the fraud and abuse counter, but then most of the providers are just trying to do the right thing and take care of the patients and provide as many visits as are necessary. And it just becomes a huge challenge. Our platform also considers maximizing the reimbursements for them by putting the right primary diagnosis and listing all the comorbidities that are extracted from those HNP. So, that's the area that we're trying to innovate and trying to see if it works, because we're able to create those personalized videos for the patients and that personalized education for them. So it's like, watching a TikTok video, or, it's like, okay, here's how your heart works. It's like a pump, like a valve. And, here are the things that are going on. So it just really helps them to know it in a way that's not very like medical knowledge or, those medical terms, because not only is that sometimes it's hard to understand, and especially for post-stroke patients, it's very hard to comprehend, as we talked about. So,
Well, and remember, right, over half of the people who experience a stroke have memory issues related to that. And you probably know just from your own background that in order to, when you provide education to someone who does not have a brain injury, you can really only expect about 10% retention. So if
wow.
you're educating someone who also has a brain injury, let alone dementia, you can't really expect them to retain that. So repetition is so critically important. And to expect, even if your home health nurse had all the time in the world to explain 100% of your ideal education, they would still need 9 follow-up phone calls in order to expect 100% retention, I would think, because you've got to allow for that like 10% each time. And
Totally.
so, yeah, exactly. So, I don't think you're overdoing it at all. And so, do you use AI agents for those follow-up phone calls at all?
We do. So we have built these voice agents that are getting the context of all of the patient history and
Mhm.
what services were performed in the first visit and
So they
what
can
was
refer back to it.
you got it. And again,
Yeah.
this is on the basis of all of their comorbidities as well, and not just the focus of care, but other things that they need to. And other conditions that may be important for them to learn based on their age, based on their demographic. I think those things are also considered there. So that's how we're trying to see how it works. But I mean, at times I also feel like, whoa, you know what? Why are we replacing the humans? Like, we're not replacing, but in a way, it just comes across as, oh, so the AI agent's going to talk to the elderly people? What do you mean? Well, we're like, listen, we're not cutting the visits. We are just in between the visits, adding an extra layer. But then the pushback could be, well, couldn't there be nurses that are sitting there? Well, yes. And I
If
think
you
that
want to
would be
pay
the
them, there
preference.
would be. Yeah.
And that
But do
would be
you want to
the,
do that?
yeah,
So it's like, do you want the outcome, or are you willing to pay the humans to do that? I mean, there is an artificial nursing shortage right now, in addition to a physician shortage. A lot of people are leaving the profession. I think if they had more opportunities where they could make these type of follow-up phone calls, then they may stay in the profession to do some remote work. There are not enough open remote positions for nurses to even have that always as an opportunity. But to my point, even if you had a nurse do one of those phone calls, what about the other 8 that I'm suggesting? Your AI agent
totally.
could do that. It totally could.
Absolutely.
And I have practiced with several AI agents. I've tried to help design some that are formatted to be really empathetic and refer back to previous conversations, even. I don't know if yours do that. Do they refer back to conversations that they have had with that patient in the past?
It has all of the context and the history. Again, not just the previous conversation, but also, as I mentioned, the discharge papers that were there, the care plan that's generated, the clinical notes that the nurse had put in as well. So yes, it references all that, and it has this 3-layer architecture of, having most weight to the latest conversation, but then also going back and being able to reference a lot of the, history of the patient, even, and that may be humanly impossible for somebody to always have top of mind. And
Well,
along
it
with
is
that,
humanly.
along with
And
that, what we
also,
also what
sorry,
we
go ahead.
also do is, like, as a co-pilot. So imagine that when the clinician's about to make that phone call, giving all that information in a visually easy to understand format to list all the, risks or certain medications that are high risk, or, other things that could, again, we're not saying that absolutely this is the way that, the future is only this one way. We are just trying to understand where the technology is right now, where the access is right now. Because for some of the patients who are not at all getting any phone calls, this may be still something that's much, much better than not having that access to that education at all.
And have you ever worked in a call center type job?
Long, long, long time ago, like 20
Did
years ago, yes.
When you had that, did you have like time limits or goal times per call?
Yeah.
Yeah. Well, that happens when you have human people. But if you have an AI agent making this phone call, they can be patient and they can go through everything that that patient on the phone can go through, right? Sometimes those people who are isolated and have these rural health like barriers, they haven't
Mhm.
talked to anybody in a long time, especially if they've had a stroke. They may be feeling really isolated. And so they may be glad to have anybody to talk to, even if it is a robot. And there are some of these AI agents. I haven't gotten to play with yours very much, but the capability exists for them to be quite like empathetic and fun to talk to and not impatient and trying to hang up and get off the phone and get on to the next call. And I do think that that not rushing is a value that needs to be accounted for as well.
Yeah, no, that's a wonderful point, because that conversation could be as
Maybe you
long
can
as you
use that
want,
as a
and
selling
that
point.
AI agent, yeah, and the AI agent's going to be super patient with, the patients. So I think that makes sense as well. That's an important point. So I think the thing is that even if I would say that fine, the agents have come a long way, but there's a long way to go. We absolutely know that because of the exponential growth that we're seeing in AI and its capabilities, and how fast it's getting so much better, because none of this existed a year ago.
Right.
Even though now the capabilities of the AI agents are getting better, like it's only going to go up from here, and providing that access to the patients is huge. You described the loneliness crisis, and I think that's one of your 9 key sort of preventative items that you talk about in one of your publications as well, that I was able to review. Talk to me more about that. What are some of the other factors besides, loneliness, that patients should keep in mind to prepare for future event? How could they prepare, for something like this? And I know there's healthy sleep, but can you describe some of the more of those things that the patients need to keep in mind?
Sure. Give me just a second. I know what you're referring to now. And actually, let's change it to brain. So I think you're referring to the episode from the Aging Like a Pro, and we're going to re-record that, and they're going to expand it to 11, but we haven't done that yet. So I'd like to refer to the American Heart Association 7 that they use. I think if they include that. So give me just a second. I'm trying to account for all.
I also made, like a quick sort of like an infographic here that I'm showing. If you can see, yeah.
Oh, there you go. Oh, will you send that to me as well?
Oh, my pleasure. Awesome. Yeah, my pleasure.
Well,
and this is the power of AI. Like, what I fed it was a lot of your information, and it helped me easily understand, because I wanted to get a good idea of what are some of the things that you have talked about. So absolutely, I'll send this to you, and a lot.
What did you use to generate this?
So this is Notebook LM. I'll show you here.
Okay. I've used Napkin AI for some like visual creations, but that's really cool.
But this one's catching a lot of traction. So I have all of this information. Like, this even like gave me a good understanding of what you do. So for any topic to prepare, I use Notebook LM. This has become sort of my go-to. I've been using it for a year now, and in the past it's gotten really better. And you would see that there's actually a video. If it's okay, I'll go ahead and play that video here. Imagine,
I want to keep this video forever. Her face is priceless. Like, I don't want to keep this, for real. Will you email this to me? This is so
It'd be my pleasure. And like I said,
you don't have to worry about any copyright or anything, because they generated it, right?
Yeah, no, you don't have to, because this you can totally use. And like I said, I fed it all of your information. So on the left side, if I could just kind of show it to you, what you do is you add a source, and you can type whatever you want and have different sources. So I was able to give it 35 sources, and there's still room for like 300 total. So from these sources, it gave me sort of a background. And then on the right side, there's a studio where these are the things that you could do. You could generate an audio overview. You could generate a slide deck. You could generate, and the way that you do it is, let's say I want to create a slide deck. So I'm going to, give it information like, create a slide deck for me that's very helpful for the patients. And it's also good for explaining the concept and the role of technology, and how we can create, how we can utilize technology for better outcomes for patients. So this is my voice scribe that I use instead of like having to type everything, which is another trick, like, that saves me so much time. And like I said, I'm really geeky about it. I like spend 6 to 7 hours just really deeply understanding a lot of these AI tools. So I hit the generate button, and it's gonna, generate the entire slide deck. And trust me, it's like really good quality. Like, it's gotten so much better in the past few, I would say, months and even weeks. Like, I even noticed something new, like this type of video that has the moving animation that wasn't there. Like, last week, you were able to only create those static image type videos, and now they've added stuff. So imagine in the coming weeks what it could look like.
Wow, that's a big leap.
Yes.
Quickly.
Yes. So that's
I've definitely seen that in images that I've generated. Like, when I'm just like making graphics, I'll have it. It'll make a really pretty picture, but it will not spell anything right.
True. And I think they're working on that.
Yeah.
hopefully in the coming few weeks, we're going to have much, much better sort of images as well, because we could not generate this like even 6 months ago, I would say, like not this
Right.
quality at all.
That's a
So
really
I'm,
great rate of increase.
yeah, I'm just so
That's
surprised
exciting.
often
That's
with
beautiful.
this. Thank you. So, and yeah, credit goes to Google's Notebook LM. And of course, I'll tell my marketing team to put all those links there, everything that we talk about here. So if people want to
Okay.
utilize that personally, or it could be one of the caregivers who might want to create certain material that's visually appealing, that explains to them
Yeah.
in a way what needs to happen. And like I said, part of what we're doing is programmatically utilizing some of these LLMs that are trained. And there's over 2 million LLMs. Believe it or not, when I read that number, I was like, oh my God, 2 million models that are out there. And there are very specialized models as well that are just focused on healthcare and that are trained on higher quality data. They may have much higher token rate for input output, at least initially, but there's a lot of good material out there for somebody who's wanting to look and research in this area. So
Yeah.
what I wanted to also cover was some of the ethical constraints, like as ethics and human rights are extremely important. Like there are some ethical failure modes, like with AI and digital health tools. I'd love to know more about what is your stance on how do we create ethical AI that covers, all different demographic of population, because there are minorities, and how do we make sure that the data is trained properly, and any other ethical constraints? What sort of ethical constraints should leaders and innovators keep in mind as they create these innovative tools?
Well, it really matters who is designing a program, because that any kind of bias that you have is going to probably bleed over into your construct of an LLM, for example. I mean, we just saw a lot of disruption around the use of AI in questionably unethical ways by our Defense Department. And so there was a big fight between, for example, everybody's probably aware by now, who's going to get the defense contracts with the US government. And is it going to be one LLM or another? And it came down to a question of ethics, is how it's been described to the public. And so, I mean, that's not just limited to healthcare, then, is it? I mean, those privacy concerns extend into our whole lives. But if we want to have ethical LLMs to work with, then we're going to need to make sure we're instilling in it that intention of the people who are creating it to do no harm, for example, and to build in guardrails that will preserve the validity and require checking sources as a matter of you have to do that and you're not allowed to hallucinate, right? So they're going to have to prevent that. Excuse me. Sorry, my nose keeps itching. Somebody's thinking about me. Have you heard that before?
No,
Have you
but
heard that before?
I heard that your palms are like itchy. Like different cultures have different ones. So
Oh,
no,
yeah.
I've not heard of that particular one.
Is it
And
if
then
your
also
palms are
like,
itchy, somebody's.
yeah, and then I've another one that I've heard like growing up was if your eyes are like, if your eyes are itching, then that's also like somebody's remembering you. And there's also another one, if you're sneezing, then definitely someone's remembering and thinking about you.
Somebody just wanted people to be thinking about them a lot, is what it sounds like. They're just going to every
Yes.
bodily function means somebody's thinking about me. I can relate to that.
Yeah, no,
But
but back to ethics. No, I'm very, very familiar with that issue of, one of my favorite LLMs that was not, that got banned from signing any of the government contracts. But what I really liked was that they held their ground, and I appreciate even Microsoft now saying that, hey, you know what, you got to look into it again. And I think having those basic fundamental rules that no matter what, we're not going to have our LLM be used for autonomously like killing people, like for weapons where there's no human in the loop. And I feel like that human in the loop aspect is so important because even for us, even though it costs us almost as much as we get paid for generating that document, to pay to the humans for review, we are going to spend that all day long, every day, because our hope is that by continuing to serve the patients, even if the margins are very limited, we're going to have this get better and better and provide that access so that eventually, I mean, the review time is going to be just a few minutes instead of now, even if for the human in the loop review might be 15, 20 minutes. What is your opinion on some of that?
Well, I think, it's being rolled out so quickly, thanks to a lot of our shortages in providers or nurses. One of our states in the US has started using AI to automatically refill prescriptions so that a human provider doesn't have to do that. But if things are filled incorrectly and there's harm done, it's the humans who are liable. I don't feel like we have worked that out yet, and that is not fair that licensed humans who have to go through all this training and have their livelihood at stake here are then held responsible for something that maybe they weren't looped into, or they weren't given time to do the adequate checks and balances to make sure that they are looped in and that these things are being done, in a safe way. So I'm not sure what the answer is there, but I'm really glad that we have a lot of brilliant people working on it. I've been working with the American Board of AI in Medicine, which is
Oh,
a
wow.
nonprofit organization made up of clinicians who are just as passionate about AI as you. And you should probably be friends with them if you're not already. But
No,
I'm
thank
really
you.
glad that there are a lot of clinicians who are involved who are very passionate about protecting their patients as well as alleviating the administrative burden, because we have to find that balance in order for it to work and be sustainable.
Absolutely. And I think the best way is to include, like you said, the clinicians and give them a seat on the table, give them a voice as we're designing these, innovative AI platforms and products. And this is what happened to me. So I was attending the NAC conference, the National Alliance for Care at Home, and
Mhm.
I saw a clinician do a keynote address, and the topic was, the future of EMR. The advice that she gave for the technology people was that, guys, don't just go in isolation and design these things, not knowing what the actual problems and challenges are for the clinicians. Collaborate with them. And
Yeah.
guess what? Right after the session, I went and talked to her. Her name is Kathy Duckett. And she was like, yeah, I was like, I would love to invite you to be a consultant and an advisor for us as we're designing this, to give your opinion on some of these things. And, she said yes. And guess what? Now
Great.
she's been working with us for 3 months, and she has played such an important role in designing our latest version of the platform. She's fantastic. And then similarly, I have some of the other advisors as well. Just really, they pour a lot of their knowledge and heart into this, and I'm seeing that everyone's just so excited about it. But then again, the ethics and the responsibility is very, very important. And it's also in like how you use the data and what data you use. It's tempting to be like, oh, let's just source data from wherever you can, but then getting those right permissions and de-identifying that personal information, like the personally identified information, is extremely important. And I think that's what's going to really create the long-term success for any organization for whatever mission that they're carrying forward, is what I feel
Yeah.
like.
And thank you for your
Well,
commitment to working with clinicians in order to build it. I mean, so many of these tech companies, like I just came back from Vive, and a lot of them
oh
were
yeah.
talking about death by pilot, like their AI solution gets piloted and then goes nowhere. But I mean, if you're not building it with clinician input, who do you think is the one that's going to be using it? And if you give them
Mhm.
something they can't work with, or they're not adequately trained on it, then what did you expect to happen? So I'm really glad to hear that you've integrated clinicians into the development side.
Yes. Well, thank you. Thank you. So I've got perfect closing question. I feel like I've taken it from your playbook. So if you had $1 billion to solve one healthcare problem, what would you do?
You just turn the tables on me.
Hey, that's perfectly fine.
Yeah, exactly. Because there is no healthcare without nurses. And that origin of this question that I ask people is the American Nurses Foundation did a survey of all the philanthropy that's given in healthcare, and it's about $300 billion a year, and only 1% or like 1 penny of every dollar that is given in philanthropy is directed towards nursing at all. And so the conversation around that was how can it be utilized effectively to be as productive as possible with our 1%, hypothetically. If I had $1 billion to direct into fixing things in healthcare, then I would want to invest it in nursing-led solutions, because nurses see the downstream effects and they see the gaps in care, and a lot of the times are not consulted, which is kind of the impetus for my book and encouraging nurses to speak up now about ideas that they have to fix things. And so I would want to use that to further amplify those solutions. There are some really interesting ideas around nursing-led primary or preventative care, not primary care replacing physicians or whatever, but like preventative to help people live healthier in the community in order to prevent them from developing chronic illnesses, prevent them from ending up in the hospital. And so I think prevention is the key.
Got it. Yeah, wonderful. I think imagine what impact it could have, all of the community. And it's only fair if I try to come up with an answer, and I haven't thought of it also yet.
Well, then I guess you have some time. You can come on my podcast.
I would love to anytime. So I think, see, right now, what my strategy, and I mean, I'm on a mission to just really first help, best patient outcomes and clinicians, maximizing reimbursements as well. So all three stakeholders, it makes sense. But that's from a very sort of narrow and initial perspective. I feel like that's going to be sort of the act one. But really, in the long term, I mean, I would like it to, be available for hospice, and then be available for other forms of, even like sniffs. And because, and I didn't want to go boil the ocean, because then you're not doing an effective job in any of the fields. So I just really took the time to understand how home health works, and what are the different legal and compliance and regulatory aspects of it. But as soon as we get some traction and we're able to see that we're actually making a real difference, I feel like that's when it'll be time to leverage that knowledge and incubate more teams that are on a mission to solve other challenges, downstream, upstream. And even I think hospitals have already solved many challenges because they get so much more funding than the small mom and pop home health agencies. And that's why as well, like, our solution is designed for helping really the smaller agencies that are led by a former nurse who became an entrepreneur and had let's say just a dozen, 24 nurses, and serving 3, 4, 500 patients, because the market's very fragmented, like in terms of the providers in home health. And it's only fair that they also have access to some of these tools and technologies and platforms that have been available to a lot of the larger companies and competitors. So I think that's where, like, making it available for free for everybody so they can utilize, and that in turns helps to build a much better trained AI for this purpose, is going to serve everybody better. And I think that's where I'd say that I'd use, whatever money is made available for this cause.
I mean, it's really great when you can believe in what you're doing so hard every day. Then you can sleep well at night and be excited to wake up in the morning, right?
Totally. Thank you, Rosa. This has been so fantastic. And thank you for your time. And thank you for everything that you do and serving the community and just really finding this new way. I am so impressed, and it totally makes sense. What you were doing on one-on-one, you thought that, hey, it could be done for so many more people and create those digital assets as podcasts. So kudos to what you do. You have my full support. Anything that I can do to help support, please let me know. And like I said, the least of which would be sharing, of course, some of these tools that my team just loves to explore, always looking out for new tools. And what I'd love to do is send these infographics and presentations and, also some of these tutorials for you if we discover something that could make a difference.
Definitely. Thank you so much. I mean, this has been a lot of fun of exploring.
Thank you so much. Thank you, Rosa. Looking forward to staying in touch.
Definitely.
Goodbye.